because it's a lot. Okay, the state of Ohio launched an investigation, hired 32 forensic auditors. Just the state of Ohio, just Medicare. Just Medicaid, sorry. Guess what they found? $230 million in fraud from the insurance companies in 1 year through gap pricing, what they're calling gap pricing, the whole Ponzi scheme I just explained. They are telling the state, this drug cost us $200, you owe us $200. But the state pays them the $200, they only paid $100. So they made $100 every time that script got written. The state realized that they could negotiate directly with the pharmaceutical companies and get better pricing. So the state of Ohio is saving hundreds of millions of dollars. Now multiply that times all 50 states. Now multiply that times all the federal payers, because Medicaid is just the state. The Medicare program covers the whole frickin' country.
Yes.
60% of the profits of these insurance companies is coming from the taxpayers. So we're getting killed paying taxes to give these guys all this money at the government level, but then we're getting killed on our company insurance plans. And then as a business owner, I'm getting killed because at the end of the year, they renegotiate the rates and they charge me more, right? I'm paying half of the care of my employees, my 300-something employees. And everything that costs that insurance money, they've taken a 30% markup on. That's why we're facing this mega healthcare expenditure issue in America. It's not just the pharmaceutical industries. It's the collusion and the capture of all of them working together to essentially screw all of us.
You haven't mentioned doctors, really. It doesn't sound like they're getting rich from this.
The doctors are making less and less to do more and more. In fact,
That's kind of crazy, though, because medicine is, at the core of medicine is a doctor, right?
100%. And we are facing a crisis with that. We have a booming aging population. We have a primary care shortage in America. That's why it takes 3 to 6 months to get in with primary cares. And 80% of primary cares in an interview, I think it was done by Harvard, said they will not be in this profession within 36 months. They don't want to do it anymore. It is a beatdown. These poor people are working their asses off, but they're in a system that ties their hands up.
The people getting rich are the parasites, right? They're not providing any actual service.
And then in certain states, clinicians have the right to earn into and make profit off of things. And so because the insurance companies have gotten so dirty and have cut the reimbursement rates for clinicians are now looking for ways to make money. And so oftentimes, when I say corporate capture again, it's the word of the day. When I say it, either it's one of two things. Either your doctor is an employee of the hospital and works for the hospital, which is directly controlled by the insurance company, okay? And so they're essentially an employee of the insurance company, or your clinician owns the hospital or surgery center, and then they dictate to the hospital and surgery center the protocols and procedures. And in those instances, they're oftentimes having to bill out of network, which is a whole nother racket, because when you bill out of network, you get paid a third of billed charges. So that's why when people go, what the hell? My MRI was $6,000. It's because they know that they're only going to get paid a third of what they bill United or Cigna. And so they have to inflate their bill by threefold. But the insurance company sets you up for failure by saying you have to go after the patient for any short pay. So this is where people get into these medical, bankruptcy issues, because if I go to United Healthcare when I owned a blood lab and I said, United, I want to be in network, their answer is fuck off. We don't want you in network. We don't need you. We've got blood labs that we have browbeat for 20 years and we've got them negotiated down to a dirt cheap price. We don't want another in-network lab. So I either lay everybody off and go out of business, go to a cash model, which is what I do now, or you do what's called billing out of network. And if I were to, I'm going to use blood as an example. If I were to bill the panel we run at Ways to Well, if you were to walk into a Quest, and it's happened because I've had UFC.
Quest is the biggest, right?
Yeah, I've had UFC fighters that are our clients and stuff walk into Quest and they give them an insurance card and they quote them $3,000 for our blood panel. And they'll call me and go, oh my God, dude, they're quoting me. I'm like, no. Give them our code. That it's a $300 deal and they bill me, they don't bill you. Like, I got it. And they're like, well, how can it be $300 when they're charging $3,000? And so it's because once you've billed a panel at a rate, by law in the contract, you have to bill the patient for that rate. And so if I take insurance at a blood lab and I'm out of network and I bill the insurance $300, they're going to pay me $100. I can't I'll lose money. I lose $200.
Yeah.
So I have to bill them $900 to get paid $300. Does that make sense?
Yes.
And then in the instance that the insurance denies, one of the deny depose, if they deny, I am in my contract required by law to go after you for the additional money. I have to chase
the patient.
Yes, I have to chase you down. But I never wanted $900. All I wanted was the $300 you owed me in the first place. That was it. But I can't get that because you won't give me a contract. And that's what's happening with surgery centers, MRI centers, hospitals. There's in-network and there's out-of-network. You, the patient, oftentimes pay for out-of-network benefits and coverage. And then the insurance company tries to deny it and make it impossible for you to get that. And oftentimes clinicians are out of network. Like the biggest, baddest, best, brightest minds for orthopedic surgery in the state of Texas, arguably, is University of Texas, UT Medical School. UT Medical School is kicked off of Optum and United Healthcare's plan. So if let's say you blow an ACL, the Texans, Rockets, Astros team doctors, all those guys for the most part are either at Methodist or UT. Well, you can't get to those guys because they're out of network for you. If you have an out-of-network plan, you can use it and pay a bigger copay or deductible to get to go see those guys. Does that make sense?
Yes.
But they have to bill them out of network and they'll get paid a percentage of the billed charges.
The cash model that you operate under, is that the future?
I think what I tell people is the same way these insurance companies are using AI algorithms to deny coverage, they are going to use large language models and AI to obstruct your ability to get care. The last person in the world you want digging through your underwear drawer is the federal government, but the second is the insurance companies.
Yes.
You don't want them to know your blood work. You don't, unless you need a procedure or something that's coming up that's catastrophic, because they're going to use it and use AI to screen you out of their system, right? And if they think you're headed towards a catastrophic event, like a heart attack or surgery or cancer, they're going to want to get you out of there before that manifests. And the average person is employed, or his insurance comes from their employer. And so if I'm a CEO at United and I know you're headed towards, something catastrophic, I can delay your ability to uncover that through putting these obstructions on things that don't make me money.
Come on. You think they
and
would do
you
that?
Absolutely. Like diabetes is a prime example.
Wait, hold on. You're saying that health insurance companies would intentionally keep people from knowing about a catastrophic illness?
That's why they don't allow you to get comprehensive blood work. That's why they delayed women's care. Like the OB-GYN initiatives were saying that we should be screening for certain genetic disorders in your 20s. And the insurance company said, no, we think that number should be 35. And all the clinicians go, okay, the number's 35. And so now women don't get that screening to see if their child's going to have a genetic issue unless they're over the age of 35. And there's hundreds of examples of this. So I think what happens is I'm an executive at United. The whole system's built for quarterly earnings, quarterly profits. I got to hit that number for Wall Street. Let's just say I'm managing 100,000 patient lives. Every day, month, week, I can delay those individuals is another day, week, and month that I don't spend money on a surgery. And if I deny those surgeries and only 10% of them come back and fight me on it, step one is to deny. Delay. Step two, deny. Now I've obstructed your ability to get to that. And an example would be a chronic disease
I'm sorry, I'm just fixated here to note the obvious. So what you're saying is that they don't want you to know that you could develop a life-threatening illness.
They don't want to treat preventative. And so anything preventative is proactive.
But pancreatic cancer, for example, has a survival rate that's in the single digits. But if caught early, it is survivable. And then many other examples.
So here's an example. They will say these things are expensive. So the screening tools we use in healthcare are dated. This is why we have moved to a cash pay. At our clinic, Ways to Well, we've become a big name because of Joe. Like we helped Joe, we helped Aaron Rodgers. We're in the Aaron Rodgers documentary. But everything we do pretty much is not covered by insurance. Almost everything we do wouldn't be covered by insurance anyway. And it's not that it's crazy expensive, it's that it's just not part of their ecosystem. Our job is not to push drugs. Our job is to have an intelligent conversation with patients to do the deep dive, to uncover the root cause, to explain to the patient what is happening with their body and why, and to give you, the patient, sovereignty and autonomy over your health. And so an example would be a cancer screening. At our company, our cancer screening looks at you at the cellular level and can diagnose over 200 different types of cancer at stage 0. 99% survival rate at stage 0. We know that a large majority of firefighters and first responders will develop cancer in their lifetime. At a minimal, why would we not be pre-screening all of our... They're exposed to toxins, chemicals, fires, smoke inhalation. A lot of our military personnel have been exposed to, Agent Orange and all these different, compounds in the battlefield. They disproportionately have a higher cancer rate. And we could be screening those individuals with real-world science and preventing cancer. But we don't. There's a lot of money made in chemotherapy. Did you know that the majority of an oncologist's income comes from marking up the medication itself? The chemotherapy itself is a profit center for the clinician that prescribes the chemotherapy. So
that would suggest that if chemotherapy is a profit center, then, I would assume it's overused.
Well, that's what you're going to see with everything. GLP-1s, the weight loss drugs.
I believe
it's become a frontline defense. And I have a different, I'm buddies with Callie, I'm buddies with Joe, I'm buddies with Jillian Michaels. They hate Ozempic. My thing about it is, I don't hate it. I'm pragmatic. It's a tool in the tool belt. And when utilized appropriately, it can change and save lives.
Yes.
But it is not a first-line defense.
Yes.
And it should not be used in children. And prescribing Ozempic...
That sounds sensible.
Yeah. Prescribing Ozempic without first talking about diet, lifestyle, and nutrition is like brushing your teeth while eating fucking Oreos. It's delusional. And that's what we're trying to do. You go, well, wait, why? I told you why, Tucker. They're printing fucking money off these medicines. The insurance company loves Ozempic. The pharmaceutical industry loves Ozempic. Is there a big benefit to it? Absolutely. It can help reduce the risk of chronic disease because the number one risk for almost all of these chronic diseases is metabolic disease and obesity.
Yes.
And we are chronically ill and obese as a society. And so if we can get that weight off, great. But if we don't talk about diet, lifestyle, and nutrition, we're just putting a Band-Aid on it. We got to get to the root cause. And if we're not going to address the food issue and we're not going to fix our food issue, it isn't a matter of people eating bad or good. Like it clearly is. Like diet is very, very important. It's the most important thing. I want to be clear. Even if you try to eat healthy in America, it's hard. We have over, and I think it was the 80s, we had 700 FDA approved ingredients in our food. Now there's thousands, and I think it's over 10,000 ingredients. In Europe, it's 700. There's over 10 petrochemicals, everything in our food sources, preservatives, food dyes, all of it. And they're all causing an increase in metabolic disease and these problems. They're making our food more processed, more addictive, more abusive. And then we're getting chronically ill and chronically obese. And then that leads to being chronically on medications.
Yes.
And then that leads to trillions of dollars. Like when we talk about big pharma, the insurance companies made $1.5 trillion last year. Trillion. Pharma is still in the billions. I think it was 600 or 700 billion, which is still an insane amount of money in revenue. But the insurance companies are 2.5 the size of big pharma.
And at least the pharma companies make something.
Yeah.
I mean, they do. They may
some
not have enough R&D, and they make, addictive drugs, and that's all bad. But they do make things.
Yeah.
I don't know. So, but I just want to clear this up. Do you think it's possible? It sounds likely, maybe, that chemotherapy is overprescribed.